Very good evening to one and all. I am Arpita, the moderator for today's session from the IJCP group. The topic that we are going to cover today, as we are celebrating the Prostate Cancer Awareness Month, it's prostate cancer prevention, myth and realities. As prostate cancer continues to impact men globally, it's essential to separate fact from fiction when it comes to prevention. This webinar, held in the observance of the Prostate Cancer Awareness Month, will tackle common myths surrounding prostate cancer prevention and provide evidence based insights to help individuals make informed health decisions. And yes, to uh, address this very crucial topic, we have with us someone very eminent from this field, none other than Dr. Krishnamurthy sir, and it's an privilege for me to welcome sir to our platform and to introduce him to everyone. So just giving a brief introduction of sir, he has done MS, DNB in surgery, MCH, again DNB in urology, MNA, MS. He is a consultant urologist at Lourdes and Lakshmi Hospital at Kochi. So, sir, with this very brief introduction of yours, I would now request you to please start with your presentation for today. Over to you, sir.
Thank you very much, Arpita, and my apologies for not joining you on time. There was some problem with my computer. I'm slightly old, so my computer is also a bit old. But the topic is not very old. The topic is quite pertinent. And I am happy that IJCP is celebrating this week as Prostate Cancer Awareness Week. That itself is very important because I have been fascinated by this particular entity called as prostate cancer. When you tell the name of cancer, everybody is afraid, but not with prostate cancer, I should say. Because prostate cancer, in my last 30 years of service as a urologist, practice as a urologist, I have never seen one prostate cancer which is killing a patient unless it is in the very bad end stage. So much so that I may have to call this disease probably as not a disease, it is a condition, it's a situation. And if the situation worsens, or in very small number of patients, the cancer is actually a cancer. Prostate cancer is actually a cancer. But in vast majority of them, it's just a situation. It is just that you made a diagnosis. The patient did not worry at all. Now, why I said this is because this cancer is being highlighted and promoted in some countries, probably for their own benefit. But in a country like India, when we have we have to think about a lot of other things, prostate cancer would be the last you should think of as far as the treatment goes. But then the chemo prevention of this particular prostate cancer can, to a large extent, prevent the disease from going into the second stage, which I said, the dire stage or the dangerous stage. With this introduction, I will go into the myths and realities of prostate cancer prevention. I bring greetings from the urology fraternity of Kochi. Now, as I said, the disease probably is the second most common cancer in men worldwide and the sixth leading cause of deaths, cancer-related deaths in men. But when you say cancer-related deaths, we do not know whether it is the patient dying of cancer or dying with cancer. They take both into account, so it becomes the sixth leading cause. The incidence again in India is 2 to 10 cases. That again is a large a proportion. You don't have a fixed data because majority of cases in India are not being reported to the cancer registries. But in countries like New Zealand and US, they have a very high incidence, bulk of this disease, because the identification of the disease is of utmost importance to them. And therefore, it is considered as a cause of high cancer-related death in the United States. But in countries like China and India, the mortality to incidence ratio is high. It means once you have diagnosed the disease, the mortality is very high, but not in US because the disease is identified in a very early stage. And the main contributing factor is probably delayed diagnosis in our country. The signs and symptoms of prostate cancer is not very different from a BPH or benign prostatic enlargement. Produces obstruction, it produces irritative symptoms, frequency, urgency, nocturia, etc., which can be produced by any prostate enlargement, not specific for prostate cancer per se. Probably that is the reason why we don't diagnose prostate cancer too much in our country. The diagnosis, of course, is based on digital rectal examination and laboratory tests, including PSA, prostate-specific antigen, which is very, very important in the diagnosis and assessing the prognosis of the disease, the progress of the disease. There are some peculiarities in the treatment of prostate cancer. We said very minimal symptoms at the onset. It has very indolent course, does not produce much problem, not in some, in majority. And the aggressiveness of the disease reduces with age. As one grows old, the disease becomes very, very indolent or very, very minor or of minor significance. But when metastatic, the symptoms are distressing. And the cost of treatment of carcinoma of prostate is going to be very high. So we have a large number of patients in the minimal symptom group, wherein the disease takes a very indolent course, very slow course. It's very innocent. And it is more innocent when the disease occurs in an elderly age. So the old saying, is it really needed when possible? So in the early stage, is a treatment required? Is a treatment really needed? But once it goes into the metastatic stage, whether the treatment is possible. So these are two paradigms which cannot go hand in hand. When the treatment is possible in the early stage, one does not know whether you need a treatment at all. And when the treatment is possible, is needed in the metastatic group, you don't know whether it is possible at all. Now let's go into the basics of cancer. Cancer occurs when there is an imbalance in cellular proliferation and apoptosis. On one side, you have the cells proliferating. On the other side, there is a programmed cell death, which is called as apoptosis. So once X number of cells proliferate, the X number of cells should die on the other side because of senescence. But when a cancer occurs, this apoptosis stops and only cellular proliferation occurs, differentiation and the senescence. The cells never get old and there is a disruption of pathways controlling the cellular process. So once an external exposure or an internal cause occurs, there are molecular effects which lead to DNA damage and DNA repair and mutations, which go into the biological effects, to cellular changes, then pre-cancer lesions occur and finally due to cancer. So there are external as well as internal factors affecting the molecular effects leading on to pre-cancerous stage and later to cancer. So what is chemo prevention? This is the use of natural or synthetic agents that reverse, inhibit, or prevent the development of clinically evident cancer in cancer-free individuals, or slow down the process to prevent cancers from becoming clinically significant. So you can use chemo prevention to totally inhibit the genesis of cancer in a totally cancer-free individual, or once the cancer has set in, you can prevent the cancer from becoming clinically significant. Both these come as chemo prevention. So why we select prostate cancer as an ideal candidate for chemo prevention? As we said, there is a long latency period to manifest clinical symptoms and clinically significant disease. There are effective modifiable environmental factors in carcinoma prostate which can contribute to the disease becoming in the advanced stage. It has very low mortality rate, so you can probably play around with the disease. Upstaging of the disease can be easily avoided. It's not like any other cancer. And there are effective markers in the form of prostate-specific antigens, which can identify the disease progression, which can tell you that the disease is progressing and you have to stop the chemo prevention, go into treatment per se. There is a high lifetime risk of developing prostate cancer, and as age advances, the disease course slows down. So, prostate cancer is an ideal candidate for choosing chemo prevention because there is a long latency period. The disease grows very slowly into the metastatic stage, And you have an effective marker called as PSA, which will identify whether your chemo prevention is working or not. What are the types of chemo prevention? Primary chemo prevention targets the general population of healthy individuals to prevent the development of cancer. Secondary prevention targets individuals with pre-malignant lesions to prevent the progression of this disease to frank cancer and metastasis. And tertiary prevention targets individuals with cancer to prevent the development of secondary primary cancer. So you can have primary, which prevents cancer, secondary, which prevents the cancer from going into a frank cancer stage or metastasis stage. Tertiary is chemo prevention involves the prevention of development of another cancer in a patient who is already suffering from one cancer. Now, we go into the topic per se. What are the agents useful for prostate cancer chemo prevention? The first one is the nutritional agents. We'll take the nutrients. Number one is the carotenoid. The active agent is lycopene, which is a red-orange pigment, which is highly unsaturated acyclic isomer of beta-carotene. And it is richly present in tomatoes and tomato-derived products, red fruits and vegetables. It acts as an antioxidant and antineoplastic. But the vitamin A from plant sources is more effective than vitamin A, which is obtained from animal sources due to the high fat content in the animal-based sources. So we don't want the animal fat to come into the picture when you consume vitamin A. And you can have at least 2 servings of tomato sauce or processed tomatoes products per week. And they say fresh tomatoes are less effective as the lycopene in them is less absorbed compared to the form found in processed tomatoes. So that's why we recommend tomato sauce and other products, processed tomato products, to be consumed as a chemo prevention for prostate cancer. So that is lycopene, which is present richly in your tomatoes. Soybean and soy food. The active agent is the isoflavonoid, mainly the genistein. It also contains isoflavones, phytates, phytosterols, lignans, protease inhibitors, etc. And what they do, mainly the genistein, is it gets converted into compound that exhibit weak estrogenic and anti-estrogenic action by the intestinal bacteria. And mind you, this estrogenic and anti-estrogenic properties are essential for prevention of prostate cancer. The phytoestrogens, the soy products, increase sex hormone binding globulin. You want the protein to be there because the sex hormones get bound to the globulin so that the free sex hormones are not available to produce prostate cancer. So this reduces the bioavailability of estrogens and testosterones in the body, thereby preventing prostate cancer. Isoflavones also weakly bind to androgen hormone receptors in the prostate and inhibit androgen stimulation. So basically, the genistein prevents the action of estrogens and testosterones on the receptors, leading on to the genesis of prostate cancer. The incidence of prostate cancer and its mortality is 10-fold lower in Southeast Asian men whose diet contains 50 times more plant products, including soy, compared to their Western counterparts. So, the Southeast Asian men are in a way protected from prostate cancer because of the high consumption of plant products, mainly soy food. Coming to the dietary fat, the omega-3 fatty acid obtained from fish oil is the primary dietary fat which can be anti-cancer. Though it contains saturated fatty acids, the omega-3 fatty acids exceed in the concentration compared to the saturated fatty acids in fish oils. So it acts as an antioxidant, interferes with the function of omega-6 acid, which is used by the cancer. So omega-3 fatty acid inhibits omega-6 fatty acid, which is used by the cancer cells as energy source. So it opposes the function of omega-6 fatty acid. So fish oil is good. Now we come to the green tea. It contains an active agent, epigallocatechin gallate, and is a product which inhibits the cell growth and regulates the cell cycle. And it inhibits chymotrypsin-like activity of proteasomes. So these prevent the cancer prostate to a large extent. And it is assessed that patients who consume green tea regularly were observed to have reduced levels of NF-κB in prostatectomy specimens. This NF-κB is an agent which stimulates inflammation and leads on to cancer in many patients. So when you consume large quantities of green tea is good for very many diseases and good for health. You have reduced NF-κB in the prostate, which ultimately prevents prostate cancer from developing. Coming to the vitamins and micronutrients, vitamin E. The active agent is the alpha tocopherol, which is the most prevalent chemical form of vitamin E. And it is richly present in vegetable oil, seeds, grains, and nuts. It acts as an antioxidant, free radical scavenger, inhibits the damage of biological membranes, DNA and proteins, and improves immune function, reduces the kinase 6 activity. So when the protein kinase 6 activity comes down, the cancer genesis is prevented. And only 150 international units of alpha tocopherol is recommended per day. So the vitamin E is an essential agent from any source, it can be obtained from any source, is an effective agent for chemo prevention of prostate cancer. You have vitamin D, which contains the active agent calcitriol, and you get it abundantly when you have an exposure to sunlight. It mainly inhibits the growth of primary prostate cancer cell lines, initiates apoptosis, that is programmed cell death is initiated. You have more cell death happening, alters the cell cycle progression. So this effectively reduces the prostate cancer genesis, and the dosage is 10 micrograms per day. So vitamin E and vitamin D from any source is very good as a chemo prevention for prostate cancer. Now you have the element selenium. There was a trial called a SELECT trial wherein they added selenium and vitamin E for the prevention of prostate cancer. This selenium is obtained from vegetables and grains and yeast. And it mainly activates P53, which is a protein, which is a brake protein, which prevents cancer genesis, and MAPK signaling pathways. These two are essential for having a check on prostate cancer genesis. It promotes apoptosis, so cellular death occurs, and regulates cell cycle progression. And the dosage is 200 micrograms of selenium rich yeast, which is good for reducing the prostate cancer by approximately 63%. So more amount of selenium from yeast is good for prevention of prostate cancer to a large extent. Now you have phytoproducts. The chemicals, the pharmaceutical agents. Number one is the 5-alpha reductase inhibitor. Now, you know that there are two types of 5-alpha reductase inhibitors. One is the finasteride, second is the dutasteride. Finasteride acts only on type 2, whereas dutasteride is a dual inhibitor, acting both on type 1 and type 2. Type 2, they say that it is present more in BPH. Type 1 occurs in prostate cancer. What 5-alpha reductase does is it converts testosterone to dihydrotestosterone, which is the active testosterone causing prostate cell hyperplasia and prostate cancer. So if you have an inhibitor which can prevent 5-alpha reductase, you can reduce the dihydrotestosterone in the prostate, thereby reducing the genesis of both benign prostate enlargement and prostate cancer. You have two trials. One is a PCPT, that's a prostate cancer prevention trial, wherein they used finasteride, and they found that on 7 years of follow-up, in low-grade cancers, that is Gleason score less than 6, the prostate cancer prevalence comes down by approximately 1/4 or 25%. While there is a decrease in the low stage cancer, there is a simultaneous increase in high-grade tumors to a tune of around 27%. So finasteride may reduce the low Gleason score cancers, but at the same time, if the patient is to develop a high-grade cancer, the incidence is more. The reduced trial wherein they used dutasteride instead of the finasteride, because dutasteride inhibits both type 1 and type 2. Again, when the PSA level was in the marginal, it was in the marginal level, say around 2.5 to 10 nanograms per liter. There was approximately 25% reduction in prostate cancer incidence when you take dutasteride, and the disease progression also reduced by 38%. But the problem with both finasteride and dutasteride is that they reduce prostate cancer incidence in low-risk cancers. That is, cancers with Gleason's grade, with Gleason score less than 6 and PSA between 2.5 to 10 nanograms per liter. But the risk of high-risk cancers, that is, Gleason's score more than 8, and when the PSA is more than 10, the risk is very high. So not widely recommended. Coming to the non-steroidal anti-inflammatory drugs, it is found that the COX-2 isoenzyme, coenzyme 2 isoenzyme expression is 3 to 5 times greater in patients with prostate cancer. If you have some material, some chemical which can reduce, or some drug which can reduce the COX-2 isoenzyme, like aspirin, sulindac, and ibuprofen, which can inhibit the cyclooxygenase enzyme, the COX-2 isoenzyme expression comes down, thereby reducing the onset of prostate cancer. It is found out that 16% reduction in the progression of aggressive tumors resulting in metastasis. But nobody uses NSAIDs for a long time because of the side effects. Selective estrogen receptor modulators, mainly the tormetrine, which is a beta estrogen receptor blocker, which is abundantly present in the prostate cancer cells. But unfortunately, though it has been proved in breast cancer prevention, its use in prostate cancer is still questionable and not confirmed. So we'll forget about selective estrogen receptor modulators for the time being. Now, coming to metformin, you know that obesity, metabolic syndromes, and high circulating insulin levels are linked to carcinogenesis. This is applicable for prostate cancer as well. So metformin may be useful, though evidence is not conclusive. So metformin, which is used to reduce obesity, reduce metabolic syndrome, may be useful in the prostate cancer prevention as well. Statins reduce the cholesterol levels, thereby reducing the testosterone biosynthesis. You know that testosterone is synthesized from cholesterol. It can also reduce inflammation and angiogenesis, and it can affect metabolism, cell cycle regulation, and promote apoptosis. And it is found that there is 7% risk reduction in prostate cancer when you use statins for a long time, and 20% risk reduction in high-grade and advanced cancer. So statins may be of use in patients as a chemopreventive agent for prostate cancer. Other possible agents, which are weak chemopreventive agents, they are still being assessed. Vitamin C, vitamin B1, B2, niacin, zinc, polyphenols, isothiocyanates, difluoromethylornithine, NSAIDs. These all have been linked as chemopreventive agents, but more proof and more studies are required to identify their exact role in the prevention of prostate cancer. Coming to the phytogenic agents or plant products, the isoflavonoids, which we said genistein, which is abundantly present in soybean, the flavonoids, quercetin, and lignans, androlactone. These are plant products which increase the sex hormone binding globulin. We said when the binding globulin increases, the sex hormone, the free sex hormone comes down. It also reduces progesterone, inhibits tyrosine kinase and topoisomerase, antioxidant properties, inhibits cytochrome P450 activation and angiogenesis, and inhibits intraprostatic 5-alpha reductase and aromatase. So phytogenic products, agents, or plant-derived agents have a long number of effects in preventing prostate cancer. The sources are beans, peas, soy, fruits, grains, cereals, and linseeds. So these agents are useful in chemoprevention. There are certain lab-tested chemotherapeutic agents. They are not actually chemopreventive agents, which are again being tried as chemopreventive agents for prostate cancer. These include silibinin, inositol, hecurin, epigenin, azacitidine, epigallocatechin 3-gallate, which we said is abundantly present in some of the products. So these are useful. These may be useful in the time to come. Now they are being tested as chemotherapeutic agents. Other plant products which can be of use as chemo preventive agent for prostate cancer include, number one is the pomegranate extract and grapeseed extract, which contain proanthocyanidin, can promote caspase 3 and caspase 9 mediated apoptosis. So it causes or initiates apoptosis, that is programmed cell death, thereby reducing the cancer progression. So pomegranate extract and grapeseed extracts are good. Now turmeric, which is commonly used in South India, more in South India compared to North India, it contains the chemical called as curcumin, which has anti-inflammatory, antioxidant, anti-carcinogenic, and angiogenic properties. And it reduces the tyrosine kinase activity of epithelial growth factor receptor and induces apoptosis. So turmeric containing curcumin goes a long way as a chemopreventive agent for prostate cancer. It is not only good for cancer prevention, it is also very good for reducing the inflammation. The bloodroot plant, Sanguinaria canadensis, which contains sanguinarines. The sanguinarine is an alkaloid and apoptotic agent, and it modulates cell cycle. So bloodroot plant, when available, is good. Now we come to the alcohol, mainly the red wine, which contains resveratrol, which is obtained from the grape skin. It has antioxidant, antiplatelet, and anti-atherogenic and estrogen-like effect, and it also helps in immunomodulation. So red wine is good, and men drinking 4 to 7 glasses of red wine per week have 25% lower incidence of developing prostate cancer. This is the study that tells you the benefit of red wine, which contains resveratrol as an anti-estrogen and anti-atherogenic agent. But it is not applicable for beer and other alcoholic materials. The cruciferous vegetables, mainly the broccoli and cauliflower, which contain the sulforaphane, which is an isothiocyanate. The red chili peppers or the bell peppers, or you call the capsicum, which contain capsaicin. Onions, apples, red wine, and tea contain quercetin. And all these inhibit the androgen receptor expression, induces apoptosis, inhibit angiogenesis, reduce heat shock protein expression, inhibit metalloproteases, and inhibit cytochrome P450. All these are essential for cancerogenesis. So therefore, these cruciferous vegetables may be useful for the prevention of prostate cancer or the advancement of prostate cancer. Ciflamend is a herbal preparation of 10 herbal extracts, mainly used in China. The extract is obtained from rosemary, turmeric, ginger, basil, green tea, etc., etc. It has a very high potent COX-2 inhibition effect as well as induces apoptosis. So ciflamend has been used as a plant product, an extract of 10 different plants as a prostate chemo prevention. I don't know whether this is available in India right now, but it's very popular in China. Next is lifestyle modification. Now, exercise reduces the insulin and insulin-like growth factor 1 and increases insulin-like growth factor binding protein 1. It also has immunomodulatory properties, improves the myokine and adipokine profiles. And it is found out that strenuous exercise of more than 3 hours per week or brisk walking of more than 7 hours per week are useful to prevent prostate cancer. Obesity, which touched upon, obesity increases the insulin-like growth factor 1, decreases the binding protein, decreases the sex hormone binding protein, increases the systemic inflammation, and increases oxidative stress. So obesity is not good. And when you have drugs which can reduce the obesity, or by any means if you can reduce the obesity, the prostate cancer can be prevented. And it is estimated that an increase of 5 kg per meter squared increase in BMI, body mass index, can increase the risk of prostate cancer mortality by 20%. So obesity is a very, very risk factor for cancer genesis as well as cancer progression as far as the prostate is concerned. Smoking promotes the development of more aggressive cancer and increases the mortality. This is applicable not only for cancer prostate, it is applicable for cancer anywhere in the body. So quit smoking. That will go a long way for preventing cancers, particularly prostate cancer. Sexual life, men with increased frequency of ejaculation have been found to have a lower incidence of prostate cancer. So a healthy sexual practice is good to prevent prostate cancer. The last is a vaccine. The vaccine stimulates specific tumor-associated as well as tumor-specific antigens, which in turn trigger immune response against cancer cells. Though vaccines are available for a large number of cancers, the one that has been licensed for prostate cancer prevention is the Ciplucel. Ciplucel T, which contains peripheral blood monocytes activated by PAP and GM-CSF, has been found to reduce the prostate cancer progression in castration-resistant prostate cancer. That is an advanced prostate cancer, wherein it is not resistant to your hormones. It improves the survival time by 20% in 34 months of follow-up. So, Ciplucel T may be useful in advanced prostate cancers, hormone-resistant prostate cancer, which we call as castration-resistant prostate cancer, because it improves the longevity or the cancer-free survival time by 20%. So this probably, if available freely, and if it is cost-effective, can be used. Now, what is the future of chemo prevention? When you look into the oncogenesis, we said on one side, the cells proliferate, the cells do not get senescent, the cells do not get old. On the other side, you have apoptosis, programmed cell death, which is essential to keep a balance. You don't want too many cells to proliferate and less number of cells dying. And this break is provided by the protein called as p53. So it is a break protein. It keeps a balance between the cell proliferation and cell death. And many other proteins which have been coded by genes like EGFR, etc., ultimately come and block p53. So if you have a genetic therapy by which the chromosomal anomalies like gain of chromosome 7, 8p, 8q, 10q, 16q, 18q, etc., which all predispose to high-grade prostatic intraepithelial neoplasia, which ultimately goes on to form prostate cancer, you can have a check on the cell proliferation. So chromosomal anomalies prevent the genesis of proteins, the production of proteins which are harmful or which are harmful for p53, which is a good protein, which is necessary to keep a check on cellular proliferation and apoptosis. Now, people have gone into translational science strategy, wherein oncolytic adenoviruses, these adenoviruses can get into the cell as well as into the nucleus. This is armed with chemoradiosensitizing genes combined with immune modulated intensity modulated radiotherapy. So if these adenoviruses which are tagged with IMRP can get into the oncogenic cells or the cancer cells, it can destroy specific cancer cells. The research is on in this particular field, though some research has found effect in the treatment of bladder cancer, but not so much as far as the prostate cancer goes. So probably genetic engineering and translational science strategy may be the two chemo preventive agents. Added to that, you may have the vaccines also coming into. A lot of vaccines are on the trial. So they may also come into the picture as prevention for prostate cancer. Now, to conclude, how can you prevent prostate cancer? You can have changes in the dietary practices like calorie restriction and control of obesity, increased consumption of fruits, vegetables, fibers, fish oils, soybean, tomato products, curcumin from your turmeric, sanguinarines. You can quit smoking if you're a smoker, enhance physical activity to reduce your weight, to avoid obesity, stress reduction and good sexual practices, Early detection of prostatic intraepithelial neoplasia and prostatic inflammatory atrophy. These two are the pre-malignant conditions of prostate cancer. If we can easily identify these two and then adopt measures to prevent the cancer progression, may be of great value. And finasteride or dutasteride as pharmacological agents concurrent with your statins and concurrent with your NSAIDs, but their long-term effect is questionable. But the others you can easily follow. But last but not the least, who should adopt prostate cancer chemo prevention? Not everyone in the population needs chemo prevention of prostate cancer. Patients or people who have a strong family history of prostate cancer, you stand a very high chance of getting a prostate cancer in later life. So they can adopt cancer chemo prevention. Patients with predisposing factors, obesity, diabetes, metabolic syndrome, these are ideal candidates for cancer chemo prevention because the incidence of prostate cancer is high in them. Borderline elevation of PSA, you have a set of people who have PSA between 2.5 and 10, but at the same time, your biopsy and other tests are not suggestive of prostate cancer. They may get a cancer at some point of time later in their life. So they can adopt chemo prevention and then follow up with PSA. Low risk patients who are candidates for watchful waiting, the large number of patients after the age of 70 years, when the Gleason score is less than 6, that is low cancer group, ISUP low group, the low risk group. And normally we subject them for no treatment at all. We do a watchful waiting. We follow up with repeated biopsies as well as PSA. If we can adopt chemo prevention in them, the progress can be averted. Now, diagnosed patients with comorbid diseases, you have a diagnosed prostate cancer, but he is a moribund patient because of his cardiac problem. You can't institute any treatment for them, and we do a watchful waiting. So probably to prevent the aggressiveness of cancer in them and going into a metastatic stage, chemo prevention may be a benefit to them. And lastly, people less than 50 years of age diagnosed prostate cancer in younger age. This is more risky because they have a long longevity of life. They can have advanced cancer later in their life. So when you have instituted treatment in these people who belong to the younger age group, below 50 years, you can also ask them to adopt prostate cancer chemo prevention strategies, which also may be useful along with the treatment which you are giving to them. So the old dictum, an ounce of prevention is worth a pound of cure. So if you adopt preventive measures in the appropriate patient, prostate cancer can be prevented as a primary measure, secondary measure, and tertiary measure is not needed in prostate cancer, but because development of secondary cancer in a prostate cancer is very, very remote because of its intolerant nature. Thank you very much. And thank you very much, IJCP, for giving me this opportunity to talk to you on this favorite topic of prostate cancer, especially this week wherein the IJCP celebrates the prostate cancer awareness program. Thank you very much.
Thank you so much, sir, for this beautiful presentation, I would say. So with your permission, I would like to move on to the question round.
Yeah, please.
So the first question is related to the screening controversies. That is, what are the most common misconceptions surrounding prostate cancer screening, particularly PSA testing, and how should individuals decide when to get screened?
Okay, now PSA is a double-edged sword. We said PSA is a very effective tool to identify because it is highly prostate specific. It is specific agent for the prostate cancer. But at the same time, PSA can be positive in various other conditions like you have a large BPH, a large volume BPH, you have a prostatic infection, prostatic infarction, and lot many conditions. So it's a double-edged sword. So what we recommend is not to screen the prostate. The screening has to be done when there is a strong family history of prostate cancer or you are susceptible for the disease, wherein identifying the cancer may change the course of treatment or give him a longevity as far as the prostate cancer is concerned. So only in those cases wherein identifying the prostate cancer may be of use as far as the treatment is concerned is where you do PSA screening. We don't do PSA screening routinely at all. And PSA is not necessary after the age of 70 years because even if you identify prostate cancer, you are not going to offer any treatment because the disease slows down in its progression after the age of 70 years. So don't do unnecessarily PSA. PSA, you take it as a tool. Once you have diagnosed cancer to identify the progression, yes, you have to do PSA. And in those cases where there is a strong family history of prostate, there you do PSA screen. Otherwise, forget it. It will just mislead not only the treating physician, it will mislead the patients to a large extent.
Right, sir. Sir, as you have spoken about like the genetical part, so sir, what are the preventive measures should men take who have a genetic predisposition?
Now, people who are genetically like the hereditary or familial prostate cancer, as of now, there are no genetic measures to prevent the ongoing cancer in them. You can adopt chemopreventive measures which will reduce the progression or reduce the disease from getting into the metastatic stage. That is all what is possible. And the genetic alterations are more in the theoretical stage. They are more in the experimental stage. Hopefully, they will all come in the future. But right now, there is no genetic method by which you can reduce cancer genesis as far as the prostate goes.
Right, so moving on to the next question. What are the biggest myths about prostate cancer prevention and why do this misconception persist despite advancement in medical science?
Probably we are not responsible for it. Probably the industry is responsible for it. Because as I said, prostate cancer in India, as far as from my school days or medical school days, we have been seeing so many prostate cancers, and mind you, most of them are alive now. So even after 30 years, nothing has happened to them. Though the patient may be frightened that he has got a cancer. Now, the first misconception is the patient thinks that it is a cancer. No, if you ask me, what if God comes and asks you what cancer do you want, I will say prostate cancer. Because that is the best cancer you can have in your life. Because the progression is very slow. You have effective ways of preventing it to a large extent. You have effective ways of following it up. And right now, the treatment is also very good. The myth is once you have a prostate cancer, people rush to the doctor. And even if we say that it is very intolerant, we reassure the patient, say that you just go, you forget about the cancer, you come back to us after 6 months. I'm sure that they will go to somebody else and get the treatment on and say that I am cured of the cancer. Now, it is not required at all. That cure is not required at all. If you reassure the patient, if you're very sure that the cancer is not progressing in it and he is not a candidate to get cancer, the castration-resistant prostate cancer. It's just a condition, it's just a situation, and you can reassure the patient, no treatment. But probably the industry wanted all these prostate cancers to be operated. So probably that is the myth that has been given to all the patients that you have prostate cancer and then your death is soon.
Right, so wonderfully explained. One last question. Are supplements like saw, palmetto, or medications like finasteride generally effective in reducing the risk of prostate cancer?
Yeah. Now, what the study says is they are very effective. Regarding finasteride and dutasteride, though we said that both of them can reduce prostate cancer to a large extent, and the reduction in prostate cancer is mainly for the low risk group. But if the patient gets a prostate cancer, it is going to be high risk cancer. It is going to be a bad cancer. So people actually do not know whether they should use it as a preventive measure. What we suggest is both finasteride and dutasteride are given for your benign prostatic enlargement. So people who are taking these drugs can continue it for about 3 months or 6 months, but don't take them as cancer preventive agents. If you have a low risk cancer, well, good enough, your low risk comes down if you take finasteride, but its more effect would be to reduce the benign prostatic enlargement than the prostate cancer. So right now, both of them are not approved as chemopreventive agents for prostate cancer.
Right, sir. Let me check if there are any other queries. So there's one last question. Can I take it, please?
Oh, sure.
So, are there any scientifically proven lifestyle changes or dietary modifications? So, I've already spoken about it, but still there's a question that significantly reduce the risk of developing prostate cancer.
Of course. Quit smoking. Take red wine instead of your alcohol, hardcore alcohol. Reduce weight. Good sexual practice. Stress reduction. Statins to reduce your cholesterol. So these are all lifestyle exercise, good exercise, regular exercise. If you're taking strenuous exercise, then the period can be reduced, but take regular exercise. These go a long way in the prevention of not only prostate cancer, any cancer or your even cardiac problems. So it will be very useful for you.
Right, sir. So with that, we would like to conclude the session. But before that, thank you so much for taking the time to share your invaluable insights on this very crucial topic, making such a beautiful presentation. And sir, your expert helps like shed light on such important topic. And I'm very sure those who have joined for the session has been benefited by it. So thank you once again. And thanks to all the audience for joining in, putting up their queries and making it a successful session. Thank you so much, sir. Thank you.
Thank you and good night.